it's a fragile wine. In this region, there are no trabecular bundles, and that's why most of the fractures of the femoral neck will occur in this region. It's the so-called Ward's triangle. In this region, the bone is less resistant. The second thing about the vascular supply of the hip joint is that the femoral head has two main vascular supply. The first one is the artery of the round ligament, in Latin, artery of the ligamentum teres. This is a branch of the obturatory artery, and it provides around 20% of the vascular supply of the femoral head. The second source of blood for the femoral head is the profound femoral artery. That artery gives two branches, the medial circumflex artery and the lateral circumflex artery, that form an arterial circle at the base of the femoral neck. From this circle, we have a number of vessels called the retinacular vessels that go on the surface of the femoral neck. Why is that important? It is important because if we have a displaced fracture of the femoral neck, these retinacular vessels will be interrupted and the femoral head will remain only with the artery of the round ligament. So only with 20% of its normal vascular supply. And that means that in a displaced fracture of the femoral neck, the risk of a vascular necrosis of the femoral neck is very high. The fractures of the femoral neck are more frequent in elderly females because of the osteoporosis, and usually it occurs in people of more than 60 years old after a fall on hip. This kind of fracture can occur also in younger patients after high energy traumas like car accidents, sport accidents, or falls from heights. At the clinical examination, we will see acute pain in the groin, in the hip, or in the buttock, and this pain will increase with movement. The mobility is abnormal, but it's limited by pain. The weight bearing is possible or impossible. It is possible if we have undisplaced impacted fracture, or it is impossible if we have a displaced fracture of the femoral neck. There is a shortening of the lower limb, around 1 to 2 centimeters. It's lesser than in fracture of the trochanteric region. Why? Because the fracture of the femoral neck, it's an intracapsular fracture, and this articular capsule will solidarize the two fragments. So the greater trochanter and all the femur cannot go up, but around 1 to 2 centimeters. In the fractures of the trochanteric region, which are extra-articular fractures, the shortening will be higher, will be greater, around 3 to 4 centimeters. This is the main difference from the point of view of the clinical examination. The lower limb will be in turned out position in adduction and external rotation, and the patient will present functional impotence. So the inability to use the segment as they should. The diagnosis of the fractures of the femoral neck is based, of course, of the radiological examination. We should ask for an antero-posterior Eric's view of the pelvis and the lateral Eric's view of the hip. As you can see in the two images, in the left one, we have a fracture of the femoral neck on the right, on the left side of the patient, in our right, but it's the left side of the patient. And in the second image, the image on the right, We have also a fracture of the femoral neck on the left side. There are some cases in which the patient will describe acute pain at the level of the hip, but the Eric's view appears to be normal. We have the images on the left. As you can see, the Eric's view is normal, but the patient has acute pain in the groin. If we perform a CT scan, you can see a fracture, an undisplaced fracture at the level of the femoral neck. On the left, the below image, it's a three-dimensional reconstruction after a CT scan with a fracture of the femoral neck on the left side. The three images on the right are of a fracture, of a bicycle fracture of the femoral neck. The Eric's view appears to be normal. We can't see any fracture on this image, but at the MRI procedure, we can see a fracture at the level of the base of the femoral neck. So the CT scan and the MRI are useful when the Eric's is inconclusive, but the patient has some pain at the level of the hip. There are a number of clinical and radiological signs of ascension of the greater trochanter. On the left above, we have shortening of the lower limb. The length of the lower limb is measured between the anterosuperior iliac spine and the tip of the tibial malleolus. As we already saw, there is a shortening of 1 to 2 centimeters in fractures of the femoral neck. Right above, we have the Peter line. It's a line which is drawn through the tips of the greater trochanters. In a normal pelvis, this line, the Peter line, will be a horizontal one. If we have a fracture of the femoral neck, the greater trochanter on the same side is ascended, and the line will be an oblique one. On the left below, we have the Ogston-Bryant triangle. This triangle is drawn by a vertical line drawn to the tip of the greater trochanter and a horizontal line drawn to the anterosuperior iliac spine. In a normal hip, the side AC and the side AB are equal. If we have a fracture of the femoral neck, the greater trochanter on the same side will be ascended, and the side AC of the triangle will be shortened compared to the AB side. The Melaton-Roser line, it's a line drawn to the ischial tuberosity, the tip of the greater trochanter, and the anterosuperior iliac spine. In a normal hip, all these 3 points are on the same line. If the greater trochanter is ascended, this Melaton-Roser line will be transformed in a triangle. And finally, we have the Shoemaker line, which is a line drawn through the tip of the greater trochanter and the anterosuperior iliac spine. In a normal pelvis, this line will intersect the median line above the belly button. In a fracture of the femoral neck, the greater trochanter will be ascended, and the Shoemaker line will intersect the median line below the belly button. There are a number of classifications, but we will insist only on 3 of them. We have the Delbé anatomical classification with 3 types of fracture, A, B, and C. The A fracture is a subcapital fracture. The B type, it's a transcervical fracture. That means that it's in the middle of the femoral neck. And the type C, it's a basicervical fracture. It's at the base of the femoral neck, right between the femoral neck and the trochanteric region. The second classification, it's the Powell's biomechanical classification. This classification is based on the angle formed by the fracture line with a horizontal line. We have three types of fracture, 1, 2, and 3. The type 1 fracture is a fracture in which this angle, the Powell's angle, is below 30 degrees. The type 2 fracture is a fracture in which the Powell's angle is between 30 and 50 degrees. And the type 3 is a fracture in which the Powell's angle is greater than 50 degrees. Why is that important? Because in the type 1 fracture, most of the forces at the level of the fracture line will be of the compression type. That means a stable fracture and a fracture that will unite very fast. In the type 3 fracture, most of the forces will be of the tangential shear type. That means we will have a more unstable fracture and a fracture that will unite late or not. The last classification is the Garden classification. We have 4 types of fracture, 1, 2, 3, and 4, and we will discuss each of them. The Garden 1 fracture, it's an incomplete fracture. It is stable. Usually the fragment will be positioned in abduction and coxa valga, and the clinical signs are minimal. But the most important thing is that it's an incomplete fracture. The Garden 2 fracture is a complete undisplaced fracture, and the osseous trabeculae are in line. So, first, Garden 1 incomplete, Garden 2 complete but undisplaced. Garden 3, it's a complete displaced fracture, but the osseous trabeculae are angulated, like in the image. The blood supply of the femoral head will be interrupted in most Garden 3 and 4 types fractures. And the Garden 4 fracture, it's a complete displaced fracture in which osseous trabeculae are parallel. Not on the same line, but parallel. This fracture will lead to a difficult reduction in the operating room, and it's an unstable fracture. So, to summarize, Garden 1 is incomplete, Garden 2 is complete undisplaced, Garden 3 is complete displaced with angulated trabeculae, Garden 4 is complete displaced with parallel trabeculae. The treatment. The functional treatment is indicated in patients with severe conditions, with comorbidities that will contraindicate the anesthesia or the surgical treatment. The functional treatment consists in early deambulation under analgesics and walking with partial weight bearing. We can do that because the fracture is intracapsular, and this capsule will make a solid block of fibrous tissue that will solidarize the 2 fragments. The lower limb will be shortened, but it will allow some weight bearing on this affected limb. The bed immobilization is very risky for elderly patients. So our aim, our goal is to deambulate them as soon as possible. but the surgical treatment will be always our first choice if we can perform a surgical treatment. There are two lines of action considering the surgical treatment. The first is anatomical reduction and stable fixation, and the second line of action is the hip arthroplasty. For the reduction and osteosynthesis, we can do that with 2 or 3 parallel screws, with DHAs, a dynamic hip screw, and anti-rotatory screw, or with Kirschner wires. The arthroplasty can be performed with partial prosthesis like the Moore prosthesis and the Thompson prosthesis. The first one is uncemented, the second one is cemented, or with total hip arthroplasty. Partial prosthesis means that we will remove only the femoral head, and this will be the partial prosthesis, while in a total hip arthroplasty, we will remove also the acetabulum, and we will mount an acetabular cup at this level. These are some images from the operating room. Below, you can see the orthopedic table, which is a specially designed table for surgical procedures at the level of the femur. And above, you can see the C-arm device, which is a device that will allow us to perform Eric's views of the hip inside the operating room during the surgical procedure. Above on the right, you can see a patient on the operating table, and in the back, you can see the C-arm device. Concerning the indications, in Garden 1 and Garden 2 fractures, osteosynthesis is indicated. In Garden 3 and Garden 4 fractures, we will indicate hemiarthroplasty in elderly patients and total hip arthroplasty in younger patients. There is a discussion. In young patients, osteosynthesis will be indicated in all types of fractures. And the evolution will be 1/3 of the patients will evolve towards consolidation with a viable head. 1/3 of them will evolve towards non-union, and that will require early total hip arthroplasty, while the last third will evolve towards necrosis of the femoral head, and that will require a late total hip arthroplasty. This is an example of osteosynthesis with DHS, dynamic hip screw, and an anti-rotatory screw. This anti-rotatory screw is necessary only in fractures of the femoral neck. Why? Because if we don't mount an anti-rotatory screw, the two fragments will have the tendency to rotate around the axis represented by the cervicocephalic screw of the DHS. This is the case only in fractures of the femoral neck, where the contact surface between the two fragments is diminished. In fractures of the trochanteric region, the contact surface between the two fragments are larger, and in this case, we don't need an anti-rotatory screw. So the anti-rotatory screw is indicated only in fractures of the femoral neck. Here you have some images. The left one is from the C-arm control in the operating room, and on the right, you can see an image of fracture of the femoral neck treated by osteosynthesis with 3 screws. These are the partial prostheses, the Thompson prosthesis, the Austin Moore prosthesis, and the bipolar prosthesis. The Thompson prosthesis is a cemented one, and you can see the cement around the prosthesis. The cement it's not visible on the X-ray view, so we must add, the producer the manufacturer will add some barium sulfate in order to visualize the cement on the X-ray view. In the middle, we have the Femur prosthesis. It's an uncemented prosthesis that has some windows at the level of its tail. In these windows, you will introduce autografts harvested from the greater trochanter or from the femoral head itself. And in time, in around 3 to 4 months, these grafts inside the windows will unite, will consolidate like a fracture, and it will lead to some bridges inside the windows that will make a secondary fixation of the prosthesis. We have a primary fixation in which the prosthesis introduces and blocked in the middle of the medullary canal. And after 3 or 4 months, we will have also a secondary fixation made by these bridges inside the windows of the tail of the prosthesis. Finally, the third type of partial prosthesis is the bipolar prosthesis. It has 2 articulations. The first one is between the smaller metallic head and the greater metallic head, and the second articulation is between the greater femoral head and the acetabulum of the patient. It has 3 main advantages. It will diminish the stress forces at the level of the acetabulum because some movements are performed between the smaller head and the greater head, and only a part of the movement will be transmitted between the greater head and the acetabulum. That means lesser stress at the level of the acetabulum. It acts also as a shock bumper, and the shock bumper is due to the polyethylene inside the greater head of the prosthesis. And finally, the third advantage is that it is easily transformed in the total hip prosthesis. If the patient will develop cotyloiditis in type, and we will see in another slide what is this cotyloiditis. So if the patient will evolve towards cotyloiditis, you can remove the greater head, you can mount acetabular cup on the acetabulum, and you will have a total hip prosthesis. It's called a totalization of a bipolar prosthesis. In the other 2 cases, for a Thompson prosthesis or for an Femur prosthesis, if you want to mount a total hip prosthesis, you must remove the first prosthesis, and after that you will mount a femoral stem, a head, and an acetabular cup. So it's much more complicated. It's even more complicated in the Thompson prosthesis, where you must remove also the cement, not only the prosthesis. The total hip prosthesis can be uncemented or cemented. The uncemented prosthesis on the left is formed by a metal back, an acetabular shell, an acetabular liner made from polyethylene, a femoral head, and a femoral stem. So 4 parts. For a cemented prosthesis, you have only 3 parts: the femoral stem, the femoral head, and an acetabular cup. You can see on the right the cemented around the cup and the femoral stem. Beside the 2 types, the cemented prosthesis and uncemented prosthesis, there are a number of friction couples for the total hip prosthesis. As you can see on the right above, on the left column, we have the heads of the prosthesis, and on the right, we have the material for the acetabular cup. So the femoral heads can be made from metal or ceramic, while the acetabular cups can be made by polyethylene, metal, or ceramic. The best prosthesis in the world, it's an uncemented prosthesis with ceramic on ceramic friction couple. Why? Because any total hip prosthesis will produce microparticles in time. As you can see, a standard prosthesis with a metallic head and a polyethylene cup will produce around 200 microns cubes of microparticles per year. On ceramic prosthesis, that kind of prosthesis will produce less than 1 micron cube of microparticles per year. Why are these microparticles dangerous? Because that particles will induce a local inflammatory response that will promote bone resorption in time and the loosening of the prosthesis. And you will need to remove the prosthesis and mount another one. The early complications. The early complications are usually the venous thrombosis and pulmonary embolism and the fat embolism. This is why in all patients with total hip prosthesis or partial hip prosthesis, you will indicate thromboprophylaxis with low molecular weight heparins for 30 days after surgery. The postoperative complications are infection, hematoma, skin necrosis, wound dehiscence, and hardware breakage, and all these complications are linked to the surgical procedure. For the hemiprosthesis, we have a specific complication, which is the cotyloiditis. In this complication, the metallic head, which is much harder than the cartilage, it will erode the acetabular cartilage, and the femoral metallic head will reach the bone and the hip will become painful. The patient will require replacement of the partial prosthesis with a total hip prosthesis. This is why the partial prosthesis are indicated only in elderly patients, because in the elderly patients, the survival time of the partial prosthesis will be longer than the survival life of the patient. For the total hip prosthesis, we have other two complications. First, it's the dislocation that will require reduction under anesthesia and C-arm control in the operating room. And the second complication is the loosening. It's the mobilization of the prosthesis, which will require revision. And of course, the venous thrombosis and the pulmonary embolism can be also postoperative and late complications. Examples for complications. On the right above, we have hip osteoarthritis after a fracture of the femoral neck, and that will require total hip arthroplasty. On the bottom line, on the left, we have necrosis, avascular necrosis of the femoral neck after a fracture of the femoral neck and osteosynthesis. That means that at the moment of the fracture, not only the bone, but also the arteries, the retinacular arteries were interrupted, and that leads in time to the femoral necrosis of the femoral head, and that requires replacement with total hip arthroplasty. In the middle, we have non-union of the fracture after reduction and osteosynthesis with screws, and that also requires total hip arthroplasty. And finally, on the right, we have non-union associated with necrosis of the femoral head. In this case, the patient was treated by osteosynthesis with DHS, with dynamic hip screw, and we can see the trace of the DHS after its removal. In this case, the treatment consists also in total hip arthroplasty. So all these complications, local late complications of the fracture of the femoral neck will require total hip arthroplasty. An example with dislocation of uncemented total hip prosthesis that will require reduction and under anesthesia and C-arm control in the operating room. Fractures of the trochanteric region, they represent more than 50% of hip fractures. They are also more frequent in females because of their osteoporosis, usually after 6 years of age, after a fall on hip. They can occur also in younger patients after high energy traumas like in car accidents, sports accidents, or falls from heights. We have an anatomical classification, and in this classification, the fractures of the trochanteric region can be cervicotrochanteric, pertrochanteric, intertrochanteric, subtrochanteric, trochanterodiaphyseal, or isolated fractures of the lesser or greater trochanter. We will discuss and exemplify each of these fractures. We have also the AO classification. This classification is based on a number of numbers and letters. The first number will represent the bone. So we have 1 for the humerus, 2 for the radius and ulna, and we have 3 for the femur, our subject for today. The second number will represent the segment. 1 is the proximal part, 2 is the diaphysis, 3 is the distal part of the bone. If we have a fracture at the level of the epiphysis, the first letter will represent the joint involvement. A, it's an extra-articular fracture. B, it's a partial articular fracture. And C, it's a complete articular fracture. If we have a fracture at the level of the diaphysis of the bone, the first letter A means a simple fracture, B, it's a wedge fracture, and C, it's a complete complex fracture. So if we have a fracture of the 3-1-A1 fracture, that means a fracture of the femur, because we have the first 3. It's a proximal fracture because the second number is a 1. The A means that we have an extra-articular fracture. And the last one means that it's a simple fracture. So a fracture of the 3-1-A1 type, it's a fracture of the proximal femur, which is extra-articular and simple. The cervicotrochanteric fracture, it's a fracture located where the femoral neck joins the trochanteric region. So at the base of the femoral neck, right between the femoral neck and the trochanteric region, like in the picture. A pertrochanteric fracture, it's a fracture that starts in the greater trochanter and usually ends in the lesser trochanter, but it can end above, in, or under the lesser trochanter. It can be simple or non-comminuted. That means that we have only two fragments, which is rare. Or this fracture can be a complex one, a comminuted fracture with 3 or more fragments. An intertrochanteric fracture, it's a fracture that starts below the greater trochanter and ends above the lesser trochanter. So it's a fracture that goes between the two trochanter. This is why it is called an intertrochanteric fracture. A subtrochanteric fracture is located below the two trochanters, till 5 centimeters below the lesser trochanter. If the fracture is located at more than 5 centimeters below the lesser trochanter, it's a fracture of the proximal femoral diaphysis, so not a fracture of the trochanteric region. This kind of fracture will start below the greater trochanter and it will end below the lesser trochanter in the first 5 centimeters below it. The trochanterodiaphyseal fracture will start in the trochanteric region and it will end somewhere in the proximal femoral diaphysis, like in the picture. At the clinical examination, we will see the same things as in the fractures of the femoral neck. Acute pain in the hip or in the buttock, and this pain will increase with movement. The mobility will be abnormal but limited by pain. Weight bearing is possible if we have an undisplaced impacted fracture, or it's impossible if we have a displaced fracture. The shortening will be greater. It will be around 3 to 4 centimeters, greater than in femoral neck fractures, because these kind of fractures are extracapsular, the trochanteric region fractures. So we don't have the capsule that solidarize the two fragments. And the greater trochanter and all the femur can go up more than 1 to 2 centimeters, around 3 to 4 centimeters, and the lower limb will be shortened. The lower limb is positioned in abduction and external rotation, and the patient will present functional impotence. Their diagnosis is based on the X-ray view. We should ask for an anteroposterior ARIX view of the pelvis and the lateral ARIX view of the hip. On the left, you can see a pertrochanteric comminuted fracture. It starts in the greater trochanter, it ends in the lesser trochanter, and the lesser trochanter is also fractured and displaced. The CT scan and MRI are useful when the patient has signs and symptoms for a fracture of the femoral of the trochanteric region, but we can't see any fracture on the ARIX view. On the right, you can see a three-dimensional reconstruction on a CT scan for a comminuted pertrochanteric fracture on the right side of the patient. The treatment, the conservative treatment, is indicated when comorbidities contraindicate the anesthesia or the surgical procedure. This conservative treatment consists with deambulation without weight bearing for 2 to 3 months. Why? Because this fracture, it's an extracapsular one. So we will wait for 3 to 3 months in order to obtain some union at the level of the fracture. Even if we have a malunion, union will allow the patient to walk with some weight bearing. In the fractures of the femoral neck, the deambulation is performed with weight bearing from the beginning. the surgical treatment will be usually our first choice. And the treatment consists in reduction and osteosynthesis with different devices. In this image, we have the dynamic hip screw, and this kind of device is indicated in osteosynthesis for petrohanteric and basicervical fracture. It is formed by a cervicocephalic screw, the one on the left, a plate which is fixed on the lateral part of the diaphysis with screws, and compaction screws between the two, between the cervicocephalic screw and the plate. Another device is the proximal femoral nail or the gamma nail. It is indicated in subtrochanteric and trochanterodiaphyseal fractures. It can be used also in petrochanteric and basicervical fracture, but in these cases, we will use normally a dynamic hip screw. The proximal femoral nail has a centromedullary nail and a cervicocephalic screw. So we don't have a plate on the lateral part of the diaphysis, but we have a centromedullary nail, which will be located with two screws, with one or two screws, usually two screws, like here on the right, on the left. Another example with preoperative images on the left with a subtrochanteric comminuted fracture, and on the right we have the post-operative images after reduction and osteosynthesis with a proximal femoral nail. If we have an isolated fracture of the greater or lesser trochanter, osteosynthesis will be performed with a figure of A configuration tension band. This is formed by two Kirchner wires and the figure of 8 wires, which goes under the curved extremities of the Kirchner wires and goes also to a tunnel in the middle of the trochanteric region. The complications are the same early postoperative and late. And let's try to identify some fractures of the trochanteric region. Any idea what kind of fracture it is? Someone? You can hear me, I suppose.
Yes, we can hear you.
So, let's try. It's a fracture that starts in the greater trochanter, it ends in the lesser trochanter, and it has at least 3 fragments. It's a pertrochanteric fracture. It starts in the greater trochanter, it ends in the lesser trochanter. The treatment will be reduction because it has a displaced fracture. So it's reduction and osteosynthesis with a dynamic hip screw. How about this one? It starts in the greater trochanter and it ends somewhere in the diaphysis. It's a trochanterodiaphyseal fracture. It starts in the greater trochanter, it ends in the diaphysis. The treatment will be reduction and osteosynthesis with a gamma nail. We can use also a DHS, but The gamma nail will be a better indication in this case. Any guess here? It's an easier one. Where it starts, where it ends.
The diaphysis.
Not quite. It's a fracture located in the first 5 centimeters below the lesser trochanter. So,
subtrochanteric.
Perfect, perfect. That's right. It starts below the greater trochanter. It ends below the lesser trochanter in the first 5 centimeters. It's a subtrochanteric fracture. And the treatment is, of course, displaced. The treatment consists in reduction and osteosynthesis with a gamma nail. How about this one? Where it starts, where it ends. It starts in the greater trochanter. It ends in the lesser trochanter. It has many fragments. It's a comminuted fracture. So if it starts in the greater trochanter and ends in the lesser trochanter, it will be a
Trochanteric.
yes, that's right. Good answer. It's a pertrochanteric fracture. And the treatment will be reduction and osteosynthesis with a DHS, with a dynamic hip screw. This one is a fracture of the femoral neck. It's a Garden 4. It's complete. It is displaced, and the trabeculae will be parallel. If the patient is an elderly patient, the treatment will be hemiarthroplasty. If it's a younger patient, the treatment will be arthroplasty or with a total hip prosthesis, or in a very young patient in the 20s or 30s, first we will try reduction and osteosynthesis with DHS and anti-rotatory screws or with screws. So the indication for the treatment depends on the age of the patient. How about here? It's a normal pelvis or it has something unusual?
Fracture of the pubic symphysis.
No, the pubic symphysis is normal, and our topic for today is not the pubic symphysis, so we don't look there.
Bilateral neck fracture of the...
Yes, yes, very good. It's a bilateral fracture of the femoral neck, and it's Garden 4 on both sides. There are complete displaced fracture with parallel trabeculae. The treatment will be in very young patient, patient of 25 years old. The treatment will be reduction and osteosynthesis with DHS and anti-rotatory screws or screws. For a patient around 50 years or 6 years old, total hip arthroplasty, while for a 70 or 80 years old patient, the treatment will be partial prosthesis, probably with a bipolar prosthesis. What kind of fracture do we have here? Where it is located? It's located at the base of the femoral neck. It's right between the femoral neck region and the trochanteric region. It's a basicervical fracture. Basicervical at the base of the femoral neck. The treatment will consist in reduction and osteosynthesis with a DHS. This is a more complicated one. We have a fracture on the left side. It's a Garden 2 fracture of the femoral neck. It is completed, but it's undisplaced. Garden 1 incomplete, Garden 2 complete but undisplaced, Garden 3 displaced, complete with angulated trabeculae, Garden 4 complete, displaced with parallel but translated trabeculae. Fractures of the femoral diaphysis. The mechanism can be a direct one when a traumatic agent will act directly on the femoral diaphysis, like in horseshoe trauma or car accidents or sport accidents, or the mechanism can be an indirect one when the flexion or the normal course of the femur will be exaggerated by the traumatic agent. Flexion will produce, will lead to transverse or oblique fracture, while a torsion mechanism will produce a striated fracture. Again, the AO classification. We are at the level of the femoral diaphysis, so the first number will be a 3 because of the femur. The second number will be a 2 because we are at the level of the diaphysis. The first letter will be an A if the fracture is a simple one. It will be a B if we have a wedge fracture, or it will be a C if the fracture is a complex one. At the clinical examination, we will have the same signs and symptoms as always in orthopedics. Pain, swelling, the walking is impossible, shortening of the lower limb, vicious position of the lower limb in external rotation, abnormal mobility at the level of the thigh, osseous crepitations, and functional impotence. In order to diagnose it, we will ask for anteroposteriors and the lateral X-ray view of the thigh. And in orthopedics, you should ask to visualize a joint above and a joint below the fracture. So in our case, at the level of the femur, on the RX view, you must see the hip and the knee. In some cases, angiography is useful if you suspect a vascular lesion, because at this level, we have a number of great vessels, the profound femoral artery and the femoral arteries and veins, and a lesion at this level is life-threatening. The complications are the same. The most dangerous complication is the traumatic shock, because if we have a lesion at the level of the great vessels, the patient can lose 2 to 3 liters of blood in a matters of seconds, even minutes, even seconds. And this kind of lesion is life-threatening. The treatment can be non-operative, or surgical treatment. The non-operative treatment consists in skeletal traction, which is usually used as a temporary immobilization till the surgical treatment, or it can be used as definitive treatment if there are contraindications for the surgical treatment or for anesthesia. The skeletal traction will decrease pain, it will prevent complications like the vascular lesions, and it will make the intraoperative reduction to be easily performed. Another kind of non-operative treatment is the immobilization in an orthesis. It is indicated when there are contraindications for the surgical treatment, but it's very difficult to use this kind of immobilization for a fracture of the femur, because any immobilization must immobilize a joint below and a joint above the fracture. That means an orthesis that immobilizes the hip and the knee. If it is very easy to immobilize the knee, it is very difficult to immobilize the hip. And that means that this patient will be immobilized in bed, and that's very risky for a patient. So our first choice will be always the surgical treatment. The non-operative treatment is indicated only as temporary immobilization till the surgical treatment, or when we have comorbidities, other diseases that contraindicate the surgical treatment. So the surgical treatment will be our first choice, and the treatment consists usually in closed reduction and osteosynthesis with a central medullary nail. This central medullary nail will be introduced in the surgical operating room, of course, under C-arm control and on an orthopedic table. For the femur, the nail can be introduced anterograde or retrograde. Anterograde means that the nail will be introduced through the greater trochanter. A retrograde nail is a nail that is introduced through the intercondylar notch. That's the case only for the femur, because for the tibia, we have only anterograde nails. So for the femur, anterograde and retrograde. For the tibia, only anterograde nails. So the nail can be anterograde or retrograde, and it can be unlocked, dynamically locked, or statically locked. Statically locked means that we have screws in the round holes in the proximal part and the distal part of the femur. And in this case, the nail will be locked. There are no movements at the level of the fracture line. No compression, no rotation. It's statically locked. A dynamically locked nail, it's a nail that is locked in oval holes or locked only proximally or distally. It is called a dynamically locked nail because rotation is blocked, but the patient, by walking with weight bearing, will allow compression at the level of the fracture line, and this compression will promote union. An unlocked nail is a nail without any screws, no proximal screws, no distal screws. And finally, these nails can be rimmed or unrimmed. An unrimmed nail is it's a thin nail that's it is introduced without reaming, while a reamed nail, before you introduce the nail, you will ream the centromedullary canal with a flexible reamer. In children, you cannot use thicker nails like in adults. You will use elastic nails because of the growth plates. You must not traumatize the growth plates, because if you do so, you will impair the growing of this femur, and this lower limb will be shortened in the adult. Another kind of osteosynthesis is the open reduction and osteosynthesis with plates. There are normal plates which are unlocked, and there are locked plates. In the locked plates, which are the best, the screws have two threads, one for the bone and the second one for the plate. And by tightening these screws, these locked screws will lock in the plate. And on the right, you have an example for a fracture of the femur after reduction and osteosynthesis with a locked plate. Our first choice is the nail, because after reduction and osteosynthesis with a nail, you can allow the patient to walk with partial weight bearing from the start, depending on the fracture, of course, of number of fragments. If you treat the patient by reduction and osteosynthesis with plates, you cannot allow walking with weight bearing for the first 3 months. You must wait for the fracture to unite before walking with weight bearing. So, for a nail, walking with partial weight bearing from the start. For a plate, walking with weight bearing at 3 months after surgery. This is why we prefer reduction and osteosynthesis with nails. The external fixator is indicated in open fracture, because if in the open fracture you cannot introduce a foreign metallic body at the level of the fracture, of the open fracture, because there is a risk of infection. And in these cases, you will perform fixation with an external fixator that will not introduce any metallic object at the level of the fracture line. Fractures of the distal epiphysis of the femur. These fractures can be extraarticular or intraarticular. The supracondylar fractures are extraarticular. The supra and intercondylar fractures are intraarticular, while the unicondylar fractures are intraarticular. For the unicondylar fractures, which are intraarticular, we have a peculiar case called the Hoffa fracture. This Hoffa fracture, it's a fracture of the femoral condyle with the fracture plane in the frontal vertical plane. That means that the posterior convoluted part of the condyle is fractured. On the left, you can see sagittal slice on a CT scan with the Hoffa fracture. The next image is the intraoperative image on the C-arm device after reduction and osteosynthesis with screws. On the right part, you can see another Hoffa fracture The first two images are X-rays views of the knee. The third one is a sagittal slice on a CT scan. You can see the fracture, which is almost in the vertical plane, and the convoluted part of the femoral condyle is fractured and displaced. The fourth image, is the postoperative image after reduction and osteosynthesis with screws. The mechanism for the fractures of the distal epiphysis of the femur can be direct mechanism when the traumatic agent will impact on the condyles, or usually we have an indirect mechanism when the patient is falling on feet with knee in valgus or varus. The AO classification is the same thing, and at the clinical examination we will see the same things: pain, swelling, deformity of the region in valgus or varus, ecchymosis in the popliteal space, the walking is impossible, some shortening of the lower limb, vicious position of the lower limb in valgus or varus with lower limb in external rotation below the knee, abnormal mobility or antalgically limited mobility, osseous crepitation, functional impotence, and so on. We must check the pulse in the dorsal artery of the foot and in the posterior tibial artery, and you must check the sensibility and the motility in the territories of the peroneal and tibial nerves. In order to diagnose the fracture, we will ask for anteroposterior and lateral X-rays views of the knee. Angiography useful if you suspect a vascular lesion. At this level, we have the femoral arteries and veins, and below them the popliteal arteries and veins, which are great vessels. The CT scan is useful in order to determine the lines of fracture, the number of fragments, their dimensions, and their displacements. And the MRI is useful in order to detect all lesions of the soft tissues. Because at this level, at the level of the knee, we have not only bones, but also soft tissues. We have the meniscus, the articular capsule, the ligaments, the cruciate ligaments, the collateral ligaments, and in many cases we have lesions not only of the bones, but also lesions of these soft tissues. And these lesions of the soft tissues must also be treated, because if we don't do that, we will have a very nice united fracture, but the patient will have a laxity at the level of the knee. So we will treat not only the fractures, but also the lesions of the soft tissues. The complications are the same: early, postoperative, late, blah, blah, blah. The treatment. The non-operative treatment consists in skeletal traction and immobilization in orthesis. The skeletal traction is used as a temporary immobilization till the surgical treatment, and this skeletal traction will be mounted to the tibial tuberosity, and the lower limb will stay on a brown splint with the knee in limited flexion. Or this skeletal traction can be used also as definitive treatment if there are contraindications for the surgical treatment. In this case, the skeletal traction will be used for 4 to 6 weeks, and after that, the lower limb will be immobilized in an orthesis. This kind of treatment is indicated only when there are contraindications for the surgical treatment, which is our first choice for this kind of fracture. The surgical treatment will consist in open reduction and internal fixation with plates and screws, with a blade plate, or with a DCS, a dynamic condylar screw. It's the same thing as a DHS, as a dynamic hip screw. The only main difference being the angle between the main screw and the plate. For a DHS, for a dynamic hip screw, this angle is between 135 and 145 degrees. For a dynamic condylar screw, the angle is of 95 degrees, because this kind of device must be adapted at the anatomy of the region. If we perform an open reduction and internal fixation, the advantage is that we obtain the best possible reduction, because you can manipulate by hand the fragments. But there are two disadvantages. One, the first one, is that this procedure will open the site of the fracture. That means we will lose the hematoma, which contains all sorts of substances and cells that promote union. And the second disadvantage is that this kind of osteosynthesis is inferior from the biomechanical point of view to the centromedullary nail. Why? Because we will concentrate all the forces on the lateral cortex. In a normal bone, these forces are concentrated right in the middle of the bone, where we can mount a centromedullary nail. So the first option is open reduction and internal fixation. The second choice is reduction and osteosynthesis with a retrograde centromedullary nail. Here we have an example with osteosynthesis with dynamic condylar screw. On the left, we have supracondylar fracture, and after reduction and osteosynthesis with DHS. The angle between the condylar screw and the plate is 95 degrees. On the right above image, we can see the plate of the DHS, the condylar screw, and the compression screw. The osteosynthesis with centromedullary retrograde nail, the so-called retronail, is indicated in supracondylar fractures. It can be also used sometimes in supra and intercondylar fractures. The advantages are it's a mini-invasive procedure which does not open the site of the fracture. By doing this, we will retain the hematoma, which contains all sorts of substances and cells that promote union. It is also superior from the biomechanical point of view to the plates, because it will concentrate all the forces in the middle of the bone. The main disadvantage for the retronail is that the reduction is obtained only by orthopedic maneuvers and is more difficult to obtain a better reduction. Examples. On the left, we have supracondylar fractures, and in the middle, we have the post-operative image after reduction and osteosynthesis with a retronail which is statically locked. That means that we have locking screws in the round holes in the distal and proximal part of the nail. And on the far right, we have another post-operative image at 1 year after the primary surgery, after the removal of the retronail. You can see the union at the level of the fracture. Another kind of osteosynthesis is the osteosynthesis with a locking plate. And we have here an example. It's a supra and intercondylar fracture. The best image is the one in the middle on a three-dimensional reconstruction on a CT scan. You can see fractures in the form of the letter T, so a supracondylar fracture and an intercondylar fracture. And on the right, you can see the post-operative image after reduction and osteosynthesis with a locking plate. That means a plate with screws with two threads, one for the bone and the second one for the plate. And when we tighten this kind of screw, the screw will be locked inside the plate. It's like mini internal fixator. Let's try to guess a number of fractures. What kind of fracture is it?
Of the femoral diaphysis.
Yes, that's right. It's a fracture of the diaphysis of the femur. What about the treatment? What you will indicate in such a case?
Centromedullary nail.
Yes, a centromedullary nail. And in this case, I will indicate reduction and osteosynthesis with an antero-retrograde dynamically locked nail. Why anterograde? Because if we introduce the nail through the greater trochanter, all the operation is extra-articular. If we introduce the nail through the intercondylary notch, so a retrograde nail, you will enter the knee joint. So you will produce a lesion at the level of the knee. This is why between the anterograde and a retrograde nail, we prefer in most cases an anterograde nail. Of course, if the fracture is distally, very distally located, just above the knee, you will prefer a retrograde nail. But in this case, the best option is reduction and osteosynthesis with an anterograde dynamically locked nail. And in this case, the patient will be allowed to walk with weight bearing at 1 or 2 days after surgery. This one, it's a more complicated one. Let's try to guess what kind is it. It's a supra and intercondylar fracture. We have a fracture line here. This is the supracondylar fracture. And we have another fracture here between the two condyles. It's the intercondylar fracture. So it's a T fracture, which is a supra and intercondylar fracture. In this case, we will perform reduction and osteosynthesis with a DCS, dynamic condylar screw, or with a locked plate. Walking with weight bearing will be allowed at 3 months after surgery. How about this one? Any ideas? An educated guess, maybe?
It's the same as the previous?
Yes, you're right. Very good. It's a supra and intercondylar fracture, and the treatment will be, of course, the same. Reduction, because it is displaced, so reduction and osteosynthesis with a dynamic condylar screw or with a locked plate. This one? It's a unicondylar fracture. It involves only one condyle. And in this case, the treatment will be reduction and osteosynthesis with 2 screws. You can also perform this osteosynthesis with a plate and screw. It's a younger patient. You can see the growth plates. So it's a teenager. Let's try it. It's a peculiar fracture. We discussed it about it. It has a name. It's a Patella fracture. It's a fracture of the femoral condyle in the frontal plane, and the convoluted part of the condyle is fractured and displaced. The treatment will be nice. The treatment will be reduction and osteosynthesis screws. And the final topic for today, it's the fractures of the patella. I think that someone let the microphone open and they do something. So,
yes, I tried to tell. Yeah, okay. They closed it.
So the patella, it's a sesamoid bone inside the extensor apparatus of the knee. It is located between the quadricipital and rotulian tendons. It is useful because it provides a longer lever arm for the extensor apparatus of the knee. And because of this patella, the forces provided by the quadriceps muscles are greater. It increases the level, the arm level for the quadricipital muscles. These fractures represent around 2 or 3% of all fractures. And the usual mechanism is the direct one, after fall on knee, which is the most frequent mechanism, or when the patella is hit with a hard object, or when the patella will impact the dashboard of a car. Another mechanism is the indirect one in violent contractions of the quadriceps, like in electrocution or in crisis of epilepsy. At the clinical examination, we will see pain, swelling of the knee because it's an intra-articular fracture and the patient will have hemarthrosis, deformity of the region, walking is difficult or impossible, the mobility of the knee will be ontologically limited, and at the palpation we will see osseous crepitation. If we have a displaced fracture of the patella, the patient cannot perform an active extension of the knee because a displaced fracture of the patella will interrupt the extensor apparatus of the knee. The only extensor muscle of the knee is the quadriceps muscle. In a displaced fracture of the patella, the tendons of the quadriceps muscle is interrupted and the patient cannot perform an active extension of the knee. There is a peculiar sign called the pen sign. In a moderately displaced fracture of the knee, if you move a pen on the patella, you will feel how the tip of the pen will fall in a ditch. And this is a pen sign for fractures of the patella. In order to determine what kind of fracture, we will ask for an antero-posterior X-ray view of the knee and, of course, a lateral X-ray view of the knee. For the patella, we have a third incidence, which is the axial X-ray view of the patellofemoral joint, the so-called skyline view. It is very useful for vertical fracture, like the one in the right image. The differential diagnosis of a fracture of the patella is made with patella bipartita. This is a multipartite patella, a common congenital fragmentation or synchondrosis of the patella, like in the A image. And this kind of congenital lesion, it's usually bilateral. And another diagnosis with which we perform a differential diagnosis are the lesions of the extensor apparatus of the knee, lesions of the tendon quadricipitalis or lesions of the rotulian tendon. Of course, that if we have an X-ray view of the knee, we will see the fracture. The treatment. The treatment, as always in orthopedics, can be an orthopedic treatment or a surgical treatment. The orthopedic treatment is indicated in fractures without displacement or with minimal displacement, or in patients with contraindications for anesthesia or for the surgical treatment. Comorbidities like renal failure, cardiac failure, myocardial infarction in the last 2 or 3 months, and so on. The orthopedic treatment consists in immobilization of the knee in a plaster cast or in a fixed knee orthosis for 6 weeks, without weight bearing for the first 3 weeks or for the whole period, depending on the type of the fracture and on its displacement. And you should indicate thromboprophylaxis for the whole period, for the 6 weeks of immobilization. The surgical treatment. The surgical treatment is indicated in displaced fractures, and we can see we have a number of options. Usually, we will perform reduction and osteosynthesis with a figure of 8 configuration tension band. Another kind of surgical treatment is the partial patelectomy, polar superior or polar inferior patelectomy with transosseous reinsertion of the tendon. Other methods of fixation are the cerclage or osteosynthesis with screws or combinations of the above. Examples. Figure of 8 configuration tension band is made by 2 Kirschner wires and the figure of 8 wire. On the right above, you can see reduction and osteosynthesis with screws. On the right below, you can see a combination between screws and wire. But the most frequent method of treatment is reduction and osteosynthesis with a figure of 8 configuration tension band. The partial patelectomy, a polar superior or polar inferior partial patelectomy, is indicated when the superior or the inferior pole of the patella have a very comminuted fracture. So you have many fragments and you cannot reduce and fix these fragments. In this case, you will remove all the fragments and you will restore the external apparatus of the knee by reinserting the restant tendon in the restant patella. That's all for today. Tomorrow we will discuss fractures of the tibia, of the ankle, of the talus, and of the calcaneus. Any questions, please?
I think it's everything okay.
I'm sorry?
I think it's everything okay, doctor.
Okay. Thank you for your attention, and we will see tomorrow at 9 o'clock. After that, my colleague, Dr. Iacobescu, we will present you